I'd like to start with a disclaimer. This is not an attempt to move to the top of the queue in an effort to return to Trinidad and Tobago. I am not engaged in political mischief, as I served as Chief of Staff of Mount Hope Women's Hospital under two different Ministers of Health, Dr. Fuad Khan of the UNC and Mr. Terence D'Alsing of the PNM, and neither expressed dissatisfaction with the quality of my work. Why now? It was necessary to be supportive of policymakers when COVID-19 was declared a global pandemic, as little was known about it. However, since then we have learned a lot. The role of social distancing and wearing a mask in reducing spread. The majority of persons who get the infection have either mild symptoms or no symptoms and recover fully. Most of the patients who require hospitalization, that is, those at risk of severe infection, have pre-existing comorbidities like diabetes, hypertension, heart disease, and obesity. PCR coronavirus tests, including point-of-care testing and antibody tests, are now available. Further, trials have shown the effectiveness of the antiviral remdesivir and other medications such as dexamethasone. Armed with this knowledge, it is now reasonable to expect policy concerning the repatriation of displaced nationals to be based on this scientific information, with logic and reasoning replacing panic, fear, and uncertainty. Instead, the process is shrouded in secrecy, lacks transparency, and appears disorganized. For me, being part of the Zika epidemic in 2016, this is all too familiar. To date, I have emailed 2 letters, as per instructions, addressed to the Minister of National Security, dated June 14th, 2020 and July 6th, 2020. I received what appears to be an automated reply on June 14th, advising that I would be contacted in a few days. I have heard nothing. I did not receive a response to the second letter. Clearly, communication is an issue. Every person needs to feel valued, especially for displaced nationals who at this time may be vulnerable emotionally and financially. In this situation, it is not what you say at a media briefing, but what you do. A follow-up message at 2-week intervals that simply asks, "How are you managing?" and provides an update would be appreciated. Even better would be a sympathetic voice call via WhatsApp. While media briefings are held at regular intervals, they appear theatrical, rhetorical, and with respect to repatriation, really offer minimal useful information. Firstly, the CMO always recites numbers which are well known to the public, as the breakdown appears on the ministry's website, newspapers, and social media. These are really the only details that are reliably provided. However, no one is aware of the names of the medical, public health experts who provide the advice on repatriation, a group that is always mentioned. This is a striking similarity in the management of the Zika crisis, when no one knew who made up the National Zika Committee. Would it not be best practice to have a database about displaced nationals with vital information such as age, geographical location, existing comorbidities, place of abode, whether rental or family, time of entry into the host country, length of permission of stay so that immigration requirements of host countries are not violated. Wouldn't such information be necessary in analyzing needs and granting exemptions? This information is certainly not available on the photo and adjoining page of our passports. And then there's the selection criteria for exemption. Again, another missing document in the public domain. Just like the policy for management of the affected Zika neonate. Not even the displaced nationals who are directly affected are privy to this list, thereby promoting the perception of bias. Further, is it a single person or a team that makes the decision? It is also perplexing that even when exemptions are granted, individuals are informed that they must make their own travel arrangements. Can the average individual charter a flight and further make arrangements with airport authorities for a flight plan to do so? Perhaps it would be prudent to examine how other countries have arranged repatriation flights out of Trinidad. Aren't these done at the government-to-government level? There is no doubt that citizens returning to the country have to quarantine for at least 14 days. It is not just quarantine, but isolation that is required, as even within a quarantine facility, there can still be commingling. The largest single number of positive COVID-19 cases in the country occurred at the Balandra camp with the first group of repatriated nationals. 40 out of 68 tested positive. Reference to this group is a staple at media briefings, including today's, as evidence of how easily the health system could be overwhelmed. However, there is no discussion that this group, the first group, was allegedly allowed to commingle. Since then, according to the ministry's own figures, thousands have been repatriated with a low infection rate. The rhetoric that every returning national has COVID-19 and will infect the country, leading to the death of all, is simply misleading. We are all aware of the cost to taxpayers of state-sponsored quarantine, as this is a point that is emphasized frequently. While this works well for countries like Australia and New Zealand, which have infinitely more resources than our small island, it is well accepted that with limited resources, management that is considered state-of-the-art may need to be modified to suit the means available. This reality is something we deal with in medicine all the time. For instance, while in Australia, a preterm baby who is 24 weeks, that is 6 months, will be resuscitated, this is not the case in our country because of limited ventilators for babies. There is no doubt that quarantine isolation has to be state supervised. However, it is baffling that in light of our limited resources and the duration of time that has elapsed, that none of our public health officials are discussing state-supervised, self-sponsored quarantine in accommodation other than hotels, such as rented apartments or homes. Clearance for such accommodation can be obtained from public health officials who can determine whether isolation is possible in such settings. There is data on infectivity rates for persons who have successfully isolated at home, or even those who tested positive for the virus and isolated at home. I am fully cognizant that the fear is for the returning national who breaks the 14-day quarantine by going out or allowing visitors and infects others, leading to an overload of our limited resource health capacity. But let's be reasonable. What is the likelihood that someone who has been away from their home for all this time, is under public scrutiny, who is desperate to return and is closely being supervised, will risk infecting others? This is not 5 months ago when the virus was unfamiliar. If these are the fears that are preventing such spaces from being utilized, they can be combined with the use of electronic bracelets to monitor individuals, or the use of private security outside homes, or the introduction of hefty fines if the terms of the isolation are compromised. Our neighbor, Barbados, a small country with far less resources than ours, has introduced the certificate of clearance. That is a negative COVID-19 PCR test within 7 days of travel. While I do not support reopening our borders to commercial air travel, can this not be incorporated into the repatriation policy for displaced nationals? Our public health officials can certainly do the calculations of likelihood of infection based on available statistics. If 1,000 people with a negative COVID-19 PCR returned at the same time, I am certain it will not be 1,000. Is it not reasonable that the same group that was successful in limiting COVID-19 in Trinidad and Tobago, that is highlighted at every press conference, is capable of repatriating its nationals in an organized, transparent, and timely fashion if they wanted to? Speak to us. You may be surprised that the displaced nationals can offer alternative, viable solutions. Thank you.